Hi guys, welcome back to the channel. So last class we have started with the squamous cell carcinoma, floor of mouth. We have seen the clinical presentation, differential diagnosis, diagnostic workup, histopath, and we have started with the treatment. So we'll be continuing that. Okay, let's start. So micro-invasive lesions or micro-invasive like T1N0M0 lesions which are 3 mm or less in thickness may be excised with frozen section control margin of at least 1.5 cm. T1N0M0 lesion 4 mm और ग्रेटर 3 mm और लेस है तो फिर फ्रोजन सेक्शन कंट्रोल मार्जिन ऑफ 1.5 सेंटीमीटर. और अगर T1N0M0 है हाँ एंड द 4 mm margin or greater than 4 mm margin, then it require a prophylactic neck treatment. T2N0M0 and T3N0M0 also required a prophylactic neck treatment, which includes bilateral functional neck dissection or radiotherapy in the range of 5000 centigrade to 6500 centigrade. तो जिनका थिकनेस T1 का कम है 3 mm से या 3 mm है तो उनको हम 1.5 सेंटीमीटर मार्जिन से हो सकता है, लेकिन जो 4 mm या ग्रेटर है और T2 और T3 लीजन उनके लिए हम लोग को बायलैटरल फंक्शनल नेक डिसेक्शन लगेगा या फिर रेडियोथेरेपी इन द रेंज ऑफ 5000 सेंटीग्रेड टू 6500 सेंटीग्रेड. नाउ N2 और N3 नेक प्रेजेंटेशन we usually go for combined surgery radiotherapy treatment, particularly surgery followed by radiotherapy within 6-8 weeks. तो N2 और N3 lesions के लिए we generally go for combined one, that is surgery plus radiotherapy. तो surgery followed by radiotherapy within 6 to 8 weeks. Now coming to the prognosis and follow-up, the overall adjusted 5-year survival rate ranges from 40% to 60%, same as oral tongue. Follow-up consisting of examination including a mirror or fiber optic examination of the laryngopharynx it is indicated every 4 months during the first 2 years and every 6 months thereafter. तो 2 साल तक हर 4 मंथ पे फॉलोअप चाहिए एंड 2 साल के बाद हर 6 मंथ पे फॉलोअप चाहिए. ओके, नाउ चेस्ट रेडियोग्राफ एंड पेट स्कैन is required. Now, so we have finished with squamous cell carcinoma of the floor of mouth. Now we'll be starting with squamous cell carcinoma of buccal mucosa. तो हम लोग क्या क्या फिनिश कर चुके हैं? squamous cell carcinoma of oral tongue, squamous cell carcinoma of pharyngeal tongue, squamous cell carcinoma of floor of mouth. Now we'll be starting squamous cell carcinoma of buccal mucosa. Coming to the clinical presentation, it accounts for 10% of all intraoral cancer, present as a red-white patch and sometimes as an exophytic mass. The lesion often are the part of a diffuse area of clinical leukoplakia, erythroplakia and may extend onto the anterior tonsillar pillar और द रेट्रोमोलर ट्राइगोन. सबसे पहले जितने भी इंट्राओरल कैंसर है उनका 10% ऑफ कैंसर स्क्वामस सेल कार्सिनोमा ऑफ बकल म्यूकोसा. सेकेंड थिंग, या तो वो रेड वाइट पैच जैसे दिख सकता है या तो एक्सोफाइटिक ग्रोथ भी हो सकता है. देन द लीजन often are part of a diffuse area of clinical leukoplakia or erythroplakia. So they are the part of diffuse area of leukoplakia and erythroplakia and they may also extend into the anterior tonsillar pillar or retromolar trigon. तो वो बकल म्यूकोसा से टॉन्सिलर पिलर और रेट्रोमोलर ट्राइगॉन पे भी जा सकता है. Now it is usually asymptomatic but can produce induration of the cheeks or a limited jaw opening. ठीक है, induration of the cheek or limited jaw opening if infiltration into the masseter or temporalis. Generally asymptomatic होते हैं लेकिन it can produce induration of the cheek and limited jaw opening if it infiltrates into the masseter and temporalis. That's all for today. We'll be continuing this in the next class. Till then, like, share, subscribe and comment. Bye.